All right, let's get right into it. Today, we're opening a case file on two conditions that can be notoriously hard to tell apart: Crohn's disease and ulcerative colitis. Now, they both fall under the umbrella of inflammatory bowel disease, or IBD. And while they look a lot alike on the surface, figuring out which is absolutely critical. So let's start digging for clues.
Both of these can cause really tough symptoms like chronic diarrhea and intense abdominal pain. They're both long-term conditions where the immune system mistakenly attacks the gut. So with all that in common, how in the world do doctors tell them apart? What are the key clues that finally give the game away?
Well, just looking at this, you can immediately see something's different. Over on the left, with Crohn's, you see those patchy, almost cobblestone-like areas of inflammation. But then look to the right, at ulcerative colitis. It's just one long, continuous stretch of disease. This right here is our very first hint that we are dealing with two completely different culprits.
To really solve this medical mystery, we have to think like detectives. We're going to follow a trail of evidence, starting with the big picture and drilling all the way down to the microscopic level to build a solid case for what makes each of these diseases so unique.
Our first and maybe most important clue is all about real estate. It's about geography. Where in the huge landscape of the GI tract does this inflammation decide to set up shop?
So here's what's wild about Crohn's disease. It can show up literally anywhere, from your mouth all the way down to the anus. Think of it like potholes on a very long road. You get a patch of bad inflammation, then a stretch of perfectly healthy tissue, then another bad patch. Those healthy gaps, we call those skip lesions. On the other hand, ulcerative colitis is way more predictable. It sticks strictly to the colon, and it always starts in the rectum and spreads upwards in one continuous, unbroken line.
And this picture shows that perfectly. See those separate red zones for Crohn's? Those are your skip lesions. Now look at the UC diagram. It's just one solid block of inflammation climbing up from the bottom. And this isn't just some textbook drawing. This is a massive distinction for a doctor doing a colonoscopy, trying to figure out what they're looking at.
Okay, let's move on to our second clue. We've looked at the map of the disease, right? Now we need to ask, how deep does the damage go? This is a huge difference, one you can see when you actually look at the tissue itself.
So to really get this, we need a quick Anatomy 101. The wall of your intestine isn't just one layer. It's got several. On the very inside, you have the mucosa. Beneath that, the submucosa, then a thick layer of muscle called the muscularis, and finally the outer wrapping, which is the serosa.
And that brings us to this key term for Crohn's disease, transmural. It's a fancy word, but all it means is that the inflammation isn't just a surface scratch. No, this is a deep, penetrating problem that goes through the entire thickness of the bowel wall, from that inner lining all the way to the outer skin.
And you can see exactly what that looks like right here. That Crohn's section has a thick swollen wall with these deep cracks or fissures. That's your transmural inflammation at work. Now compare that to the ulcerative colitis. The damage there is really superficial. It's mostly just in that top layer, the mucosa. It's kind of like the difference between a deep wound and a really bad sunburn. And believe it or not, this one single difference explains why they cause such different complications.
All right, we've looked at the crime scene from a distance, and we've examined it up close. For our final clue, it's time to break out the microscope and look for the cellular fingerprints that each disease leaves behind.
Because when you get down to the cellular level, Crohn's disease can reveal a very specific sign, a telltale sign, if you will, that helps pathologists say, aha, this is what we're dealing with.
And the classic finding is something called a non-caseating granuloma. What is that? It's just a tiny, organized little ball of immune cells that have gathered together to wall something off. Finding one of these is pretty much a slam dunk diagnosis for Crohn's. But here's the catch, they're only found in about half the cases, so pathologists also have to look for those other clues, like the deep, fissuring ulcers and those clusters of immune cells that go all the way through the bowel wall.
So if granulomas are the big clue for Crohn's, what's the smoking gun for ulcerative colitis when you're looking down that microscope?
It's this. This is the one, a crypt abscess. Take a look at the diagram. The lining of your colon has these tiny little glands called crypts. Well, in ulcerative colitis, a type of immune cell called a neutrophil just swarms into these glands, filling them up with pus and forming a tiny abscess. This is the absolute hallmark feature of UC under the microscope.
So, we followed all the clues, location, depth, and the microscopic evidence. But why does all this detective work actually matter? Well, It matters a whole lot because pinning down the right culprit has huge, real-world consequences for a patient's health, their treatment, and their future.
And this table really brings it all home. Because Crohn's is so deep and patchy, it leads to complications like strictures, where the bowel narrows, and fistulas, which are these abnormal tunnels that can connect the bowel to other organs. It's nasty stuff. By contrast, UC's damage is superficial, but because it's continuous, it carries different risks, like severe bleeding, or a dangerous condition called toxic megacolon. And here's a really crucial point. The long-term risk of developing colorectal cancer is significantly higher with extensive ulcerative colitis, which means patients need very careful, long-term monitoring.
So in the end, telling these two apart is everything. It changes the surgical plan. It decides which medications might work best. And as we get smarter about the genetics and the specific immune pathways that drive these diseases, it leaves us with one final, very hopeful question. With treatments becoming more and more targeted, will the next big clue we find take us beyond just telling them apart and lead us to truly personalized cures for every single patient? That's the goal, and that's the future of this investigation.